السلام عليكم أعزائي الطلاب. نتحدث اليوم إن شاء الله على آخر موضوع بالانفكشيوس ديزيز اللي هو بما يخص الفيرال انفكشن. أتمنى لكم الصحة والموفقية والسلامة. Measles is a highly contagious viral illness that occurs worldwide. The infection is characterized by fever, malaise, cough, coryza, conjunctivitis, followed by exantheme or rash. Following exposure, approximately 90% of susceptible individuals will develop measles. The period of contagiousness is estimated to be from 5 days before the appearance of the rash to 4 days afterward. The illness may be transmitted in public spaces even in the absence of person-to-person contacts. Patients being evaluated for measles should be isolated. Classic measles infection in immune-competent patient consists of the following clinical stages: incubation, prodrome, exantheme, and recovery. The incubation is 6 to 21 days, median 13 days. Prodrome, a 2 to 4 day prodrome phase is characterized by fever, malaise, and anorexia, followed by conjunctivitis, coryza, and cough. If present complex spots, an exantheme considered pathognomonic for measles infection typically occurs approximately 48 hours prior to exantheme. Exantheme arises approximately 2 to 4 days after onset of fever. It consists of a red maculopapular rash, which classically begins on the face and head and spreads downward. Early on, the lesions are blanching. In later stages, they are not. The rash resolves in 5 to 6 days, fading in the order it appeared. Recovery cough may persist for 2 weeks after measles. The occurrence of fever beyond the 3rd to 4th day of rash suggests a measles-associated complication. Rubella or German measles is a viral infection typically characterized by rash, fever, and lymphadenopathy. The rash is usually an erythematous desiccated maculopapular exantheme that begins on the face and spreads caudally. It usually disappears within 3 days but may persist for 8 days. Rubella is acquired through the inhalation of large particle aerosols of infectious secretions with initial infection of nasopharyngeal cells and subsequent viremia and spread to other body sites. The incubation period is usually 14 to 18 days. Virus may be shed for up to 1 to 2 weeks prior to the appearance of rash. Patients may be contagious 1 to 2 weeks before the infection becomes clinically apparent. Subclinical or asymptomatic infection is common. Rubella infection during pregnancy can lead to fetal death, premature delivery, and myriad of congenital anomalies. The most common manifestation of congenital rubella syndrome are hearing loss, developmental delay, growth retardation, and cardiac with ophthalmic defects. Primary varicella infection in children generally a mild disease compared to more severe presentation in adults or immune-compromised patients of any age. Chickenpox is highly contagious with secondary household attack rates of more than 90% in susceptible individuals. Transmission occurs in susceptible hosts via contact with aerosolized droplets from nasopharyngeal secretions of an infected individual or by direct cutaneous contact with vesical fluid from skin lesions. The clinical manifestations of varicella generally develop within 15 days after the exposure and typically include a prodrome of fever, malaise, or pharyngitis, followed by the development of generalized vesicular rash. Complication can include bacterial superinfection, while pneumonia is more common in adults. Patients with history of underlying malignancy, steroid use, or immune suppressive therapy, HIV infection, or solid organ transplantation are susceptible for disseminated varicella due to impaired cellular immunity. For healthy children less than 12 years, varicella is typically self-limited and we suggest not administering antiviral therapy. However, we suggest antiviral therapy for immune-competent children and adolescents who are at increased risk of developing complications from varicella. Example, unvaccinated patients more than 30 years old, individuals with chronic cutaneous or pulmonary disorders, those taking chronic salicylates or inhaled steroids. For immune-competent adults with uncomplicated varicella infection, we suggest oral antiviral therapy in addition to supportive care, rather than supportive care alone. Antiviral therapy can reduce the severity of symptoms and may decrease the risk of complications. We initiate antiviral therapy regardless of the individual's vaccination status. We typically administer oral valacyclovir because it can be given in few doses compared with acyclovir and has equivalent activity. Varicella zoster virus infection causes two distinct diseases. Primary infection with Varicella zoster virus result in chickenpox or varicella, characterized by vesicular lesion in different stages of development on the face, trunk, and extremities. Herpes zoster, also known as shingles, results from reactivation of latent virus infection within the sensory ganglia. The incidence of herpes zoster is influenced by the immune status of the host, age-related immune senescence, disease-related immune compromise, or iatrogenic immune suppression, with age being the major risk factor for 90% of cases of herpes zoster in adults. The presenting clinical manifestations of herpes zoster are usually characterized by rash and acute neuritis. The thoracic and lumbar dermatomes are the most commonly involved sites of herpes zoster, although any dermatome can be affected. The most common complication of herpes zoster is post-herpetic neuralgia. Other complications include herpes zoster ophthalmicus or oticus, and less commonly acute retinal necrosis, aseptic meningitis, and encephalitis. Mumps occurs worldwide since implementation of routine vaccination in the world. There has been a more than 99% decrease in mumps cases. A few hundred to few thousand cases continue to occur each year. Mumps virus is highly infectious and is transmitted by respiratory droplets, direct contact, or fomites. Viral shedding in respiratory secretions precedes the onset of symptomatic illness. The incubation period is usually 16 to 18 days from exposure to onset of symptoms. Mumps typically begins with a few days of fever, headache, myalgia, fatigue, and anorexia. These symptoms and signs are usually followed by development of salivary gland swelling within 48 hours. Parotitis may be unilateral or bilateral. Initial unilateral involvement may be followed by contralateral involvement a few days later. Carotid swelling can last up to 10 days. Mumps is usually self-limited. Most individuals recover completely within a few weeks. Infectious mononucleosis is an acute illness due to Epstein-Barr virus infection, which occurs mainly in adolescents and young adults. IM is, or infectious mononucleosis, is classically characterized by fever, pharyngitis, fatigue, and lymphadenopathy. Other findings can include splenomegaly and palatal petechiae. Cervical lymphadenopathy tends to involve the posterior chain of lymph nodes. Rare complications include splenic rupture and airway obstruction. A generalized maculopapular, urticarial, or petechial rash is occasionally seen. Rash may be more common following the administration of ampicillin or amoxicillin. Common lab findings include an absolute or relative lymphocytosis, increased proportion of atypical lymphocytes, and elevated aminotransferase. Patients with suspected IM, based upon the history and physical examination, should have a white blood cell count with differential and a heterophil test or the monospot test. We recommend not administering acyclovir for IM. Primary Epstein-Barr virus infection rarely require more than supportive therapy. A variety of symptoms and signs may be seen in association with acute HIV infection, known as the acute retroviral syndrome. The most common findings are fever, lymphadenopathy, sore throat, rash, myalgia, arthralgia, and headache. When it occurs, painful mucocutaneous ulceration is one of the most distinctive manifestations of acute HIV infection. Aseptic meningitis has also been reported. Some patients with early HIV infection may have no or only very mild symptoms. In early HIV infection, the viral RNA levels is typically very high, more than 100,000 copies per ml, and the CD4 cell count can drop transiently. Opportunistic infection can rarely occur during this transient CD4 lymphopenia. The differential diagnosis of acute HIV infection include infectious mononucleosis, Epstein-Barr virus, cytomegalovirus, toxoplasmosis, rubella, syphilis, viral hepatitis, disseminated gonococcal infection, and other viral infections. Certain features of new onset autoimmune diseases may also resemble the acute retroviral syndrome. The diagnosis requires a high level of clinical suspicion and should be considered in patients who present with consistent signs and symptoms, including an ill-defined febrile illness, neutrophil negative mononucleosis-like syndrome, and aseptic meningitis. Early HIV infection should also be considered in patients who have had a recent high-risk exposure or those who have had a recent sexual transmitted infections. Diagnosis is important since prompt initiation of antiretroviral therapy reduces the likelihood of HIV transmission. We perform the most sensitive immune assay available, ideally a combination antigen-antibody immune assay, in addition to an HIV virologic viral load test. A positive virologic test indicates HIV infection. Acute or early HIV infection is indicated if the initial immunoassay is negative, or if a combination antigen-antibody immunoassay is positive but a second antibody-only immunoassay is negative. So, HIV infection can be divided into acute HIV with seroconversion and chronic HIV with or without evidence of acquired immune deficiency syndrome or AIDS. So AIDS is defined by the CD4 cell count less than 200 cells per microliter, or the presence of any AIDS-defining condition, regardless of CD4 cell count. So the AIDS is either CD4 count less than 200 or AIDS-defining condition. AIDS-defining conditions are opportunistic illnesses or malignancies that occur more frequently or more severely in immune-compromised persons. These include mainly opportunistic infections such as pneumocystis jirovecii, toxoplasmosis, disseminated mycobacterium avium infection, certain malignancies like Kaposi sarcoma, lymphoma, as well as conditions without a clear alternative etiology thought to be related to uncontrolled HIV infection, such as wasting or encephalopathy. So effective ART or antiretroviral therapy results in sustained suppression of HIV RNA, improved cellular immunity, and reduced HIV immune activation. And we suggest indication for all patients with HIV test positive.